Dr. Smitha VK, consultant, Little Flower Hospital, Ankamali, for her talk on tailored therapy, treatment approaches in normal tension glaucoma. Over to you, ma'am.
Good morning, all. My topic is tailored therapy, treatment approaches in normal tension glaucoma. IOP lowering remains the mainstay of treatment in controlling NTG. It includes medications, laser, and surgery. Collaborating normal tension glaucoma study randomized patients to observation versus treatment group, and 30% IOP reduction reduced the progression in treatment group. Medication remains the mainstay of treatment. Prostaglandins have high efficacy. It controls 24-hour IOP and reduces the. It has best IOP lowering capabilities and it has a good safety profile. It can be used once daily and it has a neuroprotective effect on the retinal ganglion cells in animal models. Beta blockers better to avoid as it can cause nocturnal hypotension and nighttime IOP reduction is less. It should be used cautiously in bronchial asthma and bradycardia. Carbonic anhydrase inhibitors reduce aqueous production. It can have 15 to 20% IOP reduction. It can cause ocular blood flow, increase in ocular blood flow. Rho kinase inhibitors like netacidil and ripacidil improves the trabecular outflow, decreases the aqueous production and decreases the episcleral venous pressure. It increases the optic nerve head blood flow via vasodilatation, and it has a neuroprotective effect through the modulation of retinal ganglion cell apoptosis in animal model. Brimonidine is an alpha-2 agonist which decreases the aqueous production and increases the aqueous outflow. Low pressure glaucoma treatment study randomized patients to brimonidine group and timolol group, and patients treated with brimonidine were less likely to show visual loss progression compared to those receiving timolol, despite similar IOP reductions. It suggests a neuroprotective effect of brimonidine. Brimonidine inhibits the apoptosis of retinal ganglion cells in animal models through the upregulation of brain-derived neurotrophic factor. Selective laser trabeculoplasty is a non-invasive procedure. It can be done in cases when the patients are non-compliant or intolerant to medication. It may decrease the IOP about 2 to 3 millimeters. A 2-year clinical results after selective laser trabeculoplasty for normal tension glaucoma showed that 11% of eyes no longer required medications after 2 years. Surgery can bring the IOP to a single digit. Trabeculectomy can be done when the normal tension glaucoma progresses in spite of medication. The target IOP is often lower in normal tension glaucoma, so patients are at risk of hypotony. And there is 24-hour IOP control, so progression is less after trabeculectomy. Microincision glaucoma surgery can be combined with cataract extraction. It can reduce the number of drops to be used, but it's difficult to obtain the IOP below the episcleral venous pressure. So, collaborating normal tension glaucoma study showed that in spite of 30% IOP reduction, 12% of patients progressed, and in the early manifest glaucoma trial, in spite of 25% reduction in IOP, 55% of patients progressed. This suggests that factors other than IOP has role in the NTG, and so neuroprotection has a role in treatment of normal tension glaucoma. Retinal ganglion cell death occurs when there is a mechanical pressure at lamina or when there is ischemia or genetic factors which can lead to obstruction of the exoplasmic flow and depletion of neurotropic factors which can lead to disruption of mitochondria, or otherwise there is glial cell activation in the retina and lamina cribrosa which causes release of neurotoxins, and there is excess glutamate which leads to NMDA receptor activation, and there is excess inflow of calcium into the cell leading to disruption of the mitochondria and production of caspases, which leads to retinal ganglion cell apoptosis, and there is a neighbor killing effect resulting in secondary damage to the other retinal ganglion cells. Neuroprotection refers to any treatment intervention that is used to prevent the retinal ganglion cell death. Current approach is to strategies to improve the optic nerve head perfusion, rescuing the damaged retinal ganglion cell, and optic nerve regeneration. Agents to improve optic nerve head perfusion include carbonic anhydrase inhibitors, ROCK inhibitors, and calcium channel blockers like nimodipine, lomeracin, and flunarizine. Rescuing the damaged retinal ganglion cells by neurotrophins. Neurotrophins are important for the cell survival and repair, and it can be done by application of exogenous neurotrophic factors like brain-derived neurotrophic factor, ciliary neurotrophic factors, etc., or strategies for sustained endogenous expression of injected growth factors like transfection of this growth factor genes into retinal ganglion cells via viral vector, and stimulation of retinal ganglion cells with electrical activity. This ciliary neurotrophic factor can be injected into the pars plana. It provides neurotrophins and it is under the clinical trial. NMDA antagonist targets the excess glutamate, which can cause neuronal toxicity. This excess glutamate increases the intracellular calcium, which leads to a series of events leading to retinal ganglion cell apoptosis. Memantine is an NMDA receptor antagonist. It selectively blocks the excess open channels. There is an ongoing research on formulations of memantine encapsulated nanoparticles. Antioxidants like ginkgo biloba extract is a phytochemical used in the treatment of cognitive disorders. Is under clinical trial for glaucoma. And resveratrol is a phytochemical which is thought to increase the blood flow to the brain. Is also under currently under research. And optic nerve regeneration can be done by blocking the inhibitory signals and by improving the intrinsic cell growth ability and stem cell regeneration. Blocking the inhibitory signals can be done by the glial tissue release the inhibitory molecules that signal retinal ganglion cells to stop growing. Sectrin is a ROCK inhibitor. It inhibits the signaling pathways that mediate the stop signals. It could be tested for optic nerve regeneration. Enhancing the intrinsic growth ability by gene therapy based approach to target the transcription factors. Genetic therapy to overexpress the brain-derived neurotrophic factor and this receptor have enhanced the retinal ganglion cell survival. Stem cell transplantation enhanced the retinal ganglion survival when injected intraocularly in animal models. The challenge is to transform the injected cells into retinal ganglion cell phenotype. Mesenchymal human embryonic stem cells are under research now. Systemic management. NTG involves vascular and perfusion pressure issues beyond IOP, so avoid nocturnal hypertension. If using antihypertensives, have to adjust. Address the sleep apnea, migraine, and Raynaud's phenomenon. Lifestyle modifications, stop smoking, regular exercise, avoid certain yoga postures and breath holding, avoid lateral decubitus position in asymmetric glaucoma. In conclusion, IOP lowering remains the primary treatment for NTG, and ideal NTG treatment should target both IOP and IOP independent risk factors. Neuroprotection to attenuate the retinal ganglion cell death is the future.